Good afternoon, everyone. It's a pleasure for me to join you electronically. I apologize for not being there. I would have preferred to be there, but I'm still in the COVID era. Let me have my first slide. I have no conflicts of interest. Slide, please. The topic for today is New Horizons for Metabolic Surgery. Slide, please. This is a quote that I love. It comes from George Orwell's book, 1984. Who controls the past controls the future. Who controls the present controls the past. So let's delve into the past, the present, and the future in looking at New Horizons. Slide. Now, historical thought precedents. Now, the ancient Greeks thought about disease as an imbalance of four basic humors: yellow bile, black bile, phlegm, and blood. And when these things didn't mix properly, you got a disease problem. Now, Rokitansky, a wonderful pathologist, clinician, 19th century, changed that concept, changed it for all of medicine at the time to organ specific. So if you had a heart attack, it was the heart's fault. If you had an ulcer, it was the stomach's fault or the duodenum's fault. But now in the 20th century, 21st century, we're getting back to a more holistic or Greek thought process. We is involving a complex metabolic mosaic of causation. Next slide, please. Now, in 1978, Richard Varco, my mentor, my friend, and I published this book called Metabolic Surgery. And we define metabolic surgery as the operative manipulation of a normal organ or organ system to achieve a biological result for a potential health gain. Next slide. So let's look at some past examples. And it doesn't start with bariatric surgery. Back in the 19th century, 1897 to be exact, people were doing bilateral oophorectomies for metastatic breast cancer. So people, surgeons, we were taking out normal ovaries to make metastatic breast cancer shrink and for at least time period be contained. And in the 20th century, we did splenectomies. That's a normal organ for idiopathic thrombocytopenia purpura and other hematologic diseases. We did portal diversions for glycogen storage disease and juvenile Gaucher's. We did adrenalectomy for the hypertension of Cushing's syndrome, pancreas transplants for type 1 diabetes, hypophysectomy for diabetic retinopathy, cerebral stimulation and ablation for a variety of disorders. We're doing that today for Parkinson's. Pulsing electromagnetic current stimulation for bone repair. That's always fascinated me, not being an orthopedic surgeon. But if you put electrodes at either end of a broken bone, turn on the current, it heals faster. Interesting. Next slide. And the two examples, of course, that we know about, at least one, partial ileal bypass that Richard Varco and I introduced in 1962 for hyperlipidemia, and our program on the surgical control of the hyperlipidemia is the POSH program in 1990. Next slide. Now, this was the partial ileal bypass. You measure the bowel from the ileocecal valve, divided at 200 centimeters, anastomose the proximal bowel to the anterior tinea of the cecum, and then close all your mesenteric defects, or A, B, and C. Next slide. Now, this simple operation, we measured by radioisotopes the metabolic changes. Well, first of all, cholesterol absorption went down 60% because the terminal ileum is the primary site of cholesterol and bile acid absorption, and bile acids are the end products of cholesterol metabolism. Fecal steroid excretion, which is neutral sterols, and bile acids, neutral sterols, again, primarily cholesterol, went up 380%. Synthesis went up because the body tried to keep up, and cholesterol turnover went up. And remarkably, the cholesterol pools went down. Now, the pools are P1 and P2. The freely miscible pool, blood, liver, well, you expect that to go down. But we also showed by isotope analysis that the cholesterol in atherosclerotic plaques, which is the less freely miscible pool, also went down. Next slide. So here is the difference in the LDL between the control and the surgery group for 11 years. So the reduction was maintained. Next slide. In 1990, at the American College of Surgeons, we presented our clinical results. And for patients, and all these patients had one myocardial infarction. The atherosclerotic coronary heart disease mortality and non-fatal MIs went down 35% between controls and partial ileal bypass patients, highly significant. Non-fatal MIs went down. The need for CABG and PTCA went down. The overall mortality for patients with an ejection fraction over 50 went down. All that significant. And we didn't quite reach it for the atherosclerotic coronary heart disease mortality and overall mortality. Next slide, please. However, by 21 years, and we followed these patients up to 35 years, there was a difference in overall mortality. Next slide. And that was maintained to 25 years. So the partial ileal bypass, first metabolic procedure that ever warranted a large NIH trial. The POSH trial cost $65 million. And it was the first demonstration that lowering cholesterol actually preserved life, decreased heart disease, and what I didn't show, peripheral vascular disease. Next slide. Now, in 1953, again, my friend, mentor, Richard Varco did the first bariatric operation in Minnesota. He did the first jejunal ileal bypass for obesity. Next slide. And this has been our profession, basically, in IFSO. And this shows the landmark operations for the jejunal ileal bypass starting back in 1953, for gastric bypass, biliopancreatic diversion, the late wonderful Niccolo Scopanaro, vertical banded gastroplasty, again, Mason, the duodenal switch, Hess and Hess in the United States, and then stimulation of the stomach by Shigina, and then the band by Kuzmak and others, and then finally the sleeve gastrectomy, which is now the most popular operation and popularized by Dr. Gagné. Next slide. So what do we find in addition to reversing obesity with our metabolic bariatric surgery? We reverse the metabolic syndrome of type 2 diabetes, hypertension, and hyperlipidemia. We mitigate cardiovascular disease, and there are papers on this during this meeting in Miami. We neutralize NASH. We help structural changes that are abnormal in obesity, like sleep apnea and orthopedic problems. We fix endocrine problems, and we even mitigate cancer. Next slide. Now, this was recognized by our societies. In 2007, the American Society of Metabolic Surgery became the American Society for Metabolic, American Society of Bariatric Surgery became the American Society for Metabolic and Bariatric Surgery, ASMBS. And IFSO, our IFSO, added a metabolic disease to the IFSO title. Next slide, please. Now let's go to the new horizons. We've looked at the past, we've looked at the present. Where do we go with metabolic surgery? Actually, we go back once again. The first new horizon is brain stimulation for obesity. This was done in 1974 by Quad. Quad electrically stimulated the lateral hypothalamus, and he got moderate success. People lost weight. And in 2019, there was a review of attempts in various areas of the brain to influence metabolic diseases. And that was published. And all these references, I give them to you. If you want them, write me and I'll send you the references or the slides. Next slide. Next new horizon, brain and vagal stimulation for depression. Modulated chronic depression by stimulation of the subgenual gyres, 2005 by Mayberg and Associates. And then the single vagal nerve stimulation by an implanted vagal collar wired to an implanted pacer. That's an interesting story. There were two investigators, bariatric surgeons, who stimulated the vagus nerve below the diaphragm, and they got some weight loss. And they said, aha, let's do this up in the neck. Vagal nerve is much easier to reach, and we'll get some vagal stimulation, or we'll get some weight loss. He got no weight loss. But they found in their patients who had refractory depression to drugs, whatever, they were maybe not cured, but markedly improved. And so today, neurosurgeons, vascular surgeons, general surgeons, head and neck surgeons are implanting pacers on single vagal nerves for depression. Next slide, please. And this shows the diagram of that. The electrodes are implanted easily in the neck through a tiny little incision on a collar through the around the vagus nerve attached to a pacer. Next slide. Next horizon, carotid sinus stimulation for hypertension. Now here, both carotid sinuses are simultaneously stimulated by electrodes in the perivascular space connected to a pulse generator containing a mini computer to control the radio frequency impulses. And there are two references given for that. Next slide. And here you can see the diagram of it. The stimulating pacer is placed around the carotid sinus, stimulates the baroreceptors, and probably, we don't know how, but probably through the carotid sinus nerve, an impulse goes to the brain and goes to the hypothalamus, and that's what causes the effect to lower the blood pressure. Next slide, please. Perirenal vascular sympathetic ablation for type 2 diabetes. Now we're coming into our ballpark because we mitigate type 2 diabetes by bariatric surgery. And serendipity is really the mother of invention. There's a gentleman by the name of Mahoud who practices in Berlin, and he works with patients who have hypertension. And he took an old operation. I did this in the 1960s. You do a sympathectomy. I used to make little incisions in both flanks, and you lower the norepinephrine output and you lower the blood pressure. Well, he did it by passing a catheter up the femoral artery and then ablating the sympathetic nerve plexus around the vascular pedicles, both vascular pedicles. And indeed, he got a lowering of blood pressure. But he also found, amazingly, that in his patients with diabetes, the blood glucose went down. And I'll show you all this. The serum insulin went down. The peptide went down. And the insulin resistance went down, the HOMA-IR. Next slide. And this shows his diagram of renal denervation with a catheter coming up from the femoral artery. Next slide. And these are his remarkable findings with diabetes at 1 month and at 3 months. All these 4 parameters are normalized. Next slide, please. Partial ileal bypass for type 2 diabetes. Well, we reviewed the POSH data at 34 years after the trial, and we found that the partial ileal bypass group, The intervention group had 2.5 times protection from developing type 2 diabetes than the control group. Now, isn't that interesting? Now, let us postulate that we can do this operation not to prevent, not prophylactically, but to mitigate type 2 diabetes. And now, if we could do a one-day operation, simply, laparoscopically, maybe even same day, and eliminate hyperlipidemia and eliminate diabetes, what a wonderful thing that would be. And what a wonderful thing it would be for the life expectancy and the use of medication for these patients. Next slide, please. And this shows our results in the POSH group, the controls, their number of patients with diabetes and prediabetes, and in the partial ileal bypass group. Next slide. Another new horizon, the last one I'll present, bariatric surgery, namely sleeve gastrectomy. Other operations will do the same thing, I believe, for traumatic brain injury or TBI due to multiple concussions, and early chronic traumatic encephalopathy, CTE. Now, why? Well, obesity and TBI are reciprocally related. The concussion trauma patients who are obese have a greater incidence of developing TBI than those who are not obese. And the cognitive symptomatology is very similar for both. And this is outlined in a paper with over 330 references by Tim McLennan, and I'm part of that group. And we published it in 3 issues, the entire field, showing this causation hypothesis. And then there are 3 papers also in that big paper that showed that if you operate on obese patients for their obesity and the metabolic diseases we know, but they also had traumatic brain injury, that improved. The same symptoms improved. Their cognition was enhanced. And so now we're in the process of starting a trial in that area. Next slide, please. So in conclusion, open and laparoscopic traditional surgery, incisional, we drained abscesses. Extirpative, we did these massive cancer operations, and reconstructive heart valves, etc. These disciplines of surgery are giving way to pharmaceutical, endoscopic, and transvascular therapy. We're losing these areas. But metabolic surgery may become the mainstay discipline of surgery. And metabolic, currently us, metabolic bariatric surgeons can become the leaders of this transition in disciplines, as well as the research leaders in the elucidation of the metabolic mechanisms of many diseases. I thank you so much for your attention. Be delighted to answer any questions. Thank you again.